Good morning, everybody. Happily, more people are arriving, but I think we'll kick off with this session, even though people are still taking their seats. It's nice to see so many people here. Welcome to this panel on data science and artificial intelligence in the World Innovation Summit for Health. My name is Raghi Omar. I'm moderating this very distinguished panel, and it's a great honor for everyone here to join us. I want to sort of start by talking about the essence of what the subject is before us today, and the report that we'll be discussing and the experts that we'll be hearing from who took part in this study. It's about the importance, the role, and the future of harnessing data science and artificial intelligence in healthcare. Data science and AI form a part of our everyday lives, whether you are booking tickets, whether you're checking on your sort of bank accounts, whether you're checking on your children's homework. So many aspects of our lives are touched by data, including, of course, our politics, which I spend a lot of time reporting on. This is a vital issue in the modern world. But where does it relate when it comes to healthcare and the future of healthcare? And where is its importance in terms of the well-being of our loved ones and our society and our world? We want to explore some of those, and they're part of this study in this booklet, which I'm sure you can find copies of. Do take your time to read it. It's a very, very thought-provoking piece of work. Let me start off by introducing our panel. I'll start off with the far end and work my way up. At the far end is David Bates, who is the Chief Division of Internal Medicine and Primary Care at Brigham and Women's Hospital. David is also an internationally renowned expert in patient safety. He is a professor of medicine at Harvard Medical School and a professor of health policy and management at Harvard School of Public Health, where he co-directs the program in clinical effectiveness. He also directs the Center for Patient Safety Research and Practice at Brigham and Women's Hospital, and he served as an external program director for research at the World Health Organization. Dr. Annette Grossmuller joined SAP as an expert precision medicine in June of 2016, and within SAP she leads several strategic and innovative initiatives in the context of biomedical research and healthcare. Also with us is, I'm happy to say, Professor Effie Vallena. Professor Vallena is a professor of bioethics at the Swiss Institute of Technology and a renowned expert at the intersection of where medicine and data and ethics come into play, and her work focuses on important societal issues of data and technology. I'm also very happy to introduce Dr. Ahmed El-Magarmid, who's the Executive Director, founding Director at the Qatar Computing Research Institute in 2010, and he has served as the Executive Director ever since. And before joining the Qatar Foundation, Dr. El-Magarmid served as a Chief Scientist at Hewlett-Packard and Professor of Computer Science at Purdue University, and Dr. El-Magarmid serves as the Vice Chair of the IT Executive Committee of Sidra Medical and Research Center. Just along as well is Maurizio Vecchioni, and Maurizio is the Executive Vice President of Global Good and Research at Intellectual Ventures, and in this role he oversees the global goods collaboration with Bill Gates to try and invent and deploy technology specifically focused on improving life in developing countries. But also Maurizio is what I'd like to sort of describe hopefully as a serial entrepreneur. He has helped to build 9 startups and helping launch more than 50 commercial products. Their expertise goes much farther, but I'll be here forever if I kept going on and introducing all the different aspects of work. Last, but by no means least, is Professor Aziz Sheikh, who is the chair of the forum and helped oversee this report. Professor Aziz is a professor of primary care Research and Development and the director of the Usher Institute of Population Health Sciences and Informatics at the University of Edinburgh, and he holds a number of visiting chairs at universities, including Birmingham, Queen Mary's University, Maastricht in the Netherlands, and recently was appointed as a visiting professor of medicine at Harvard Medical School. I now call on Professor Aziz to make the keynote address as chair of the forum, and then we'll hear from all of our other experts. Professor Aziz.
Thanks very much indeed, Ragay, for that kind introduction. Good morning, Your Excellencies, ladies and gentlemen. It's a real pleasure to be with you here today and share some highlights from this report that I, together with colleagues, had the pleasure of putting together. I hope you have a copy available. If not, I mean, it will be available at the end of this session. So health systems across the world are facing common challenges, whether we're thinking about high-income countries or low-middle-income country environments. They're challenged by the fact that we have now aging populations. We have this demographic transition that's taken place that really has been highlighted again by the Global Burden of Disease study, which reported its latest findings last week, and that we've been through this, or are going through this epidemiological transition, in that we're moving away from infectious disorders, and what's now burdening health systems are long-term conditions. And long-term conditions where people are living with multiple, so 1, 3, 5, 7, 10, sometimes 12 long-term conditions. And as a result, healthcare costs are spiraling, and so even in the richest countries in the world, people are having to look at how we can begin to reconfigure healthcare differently. Part of that transition is moving away from our hospital-centered health systems that were put together really to treat and manage infectious disease epidemics and deal with the casualties of war, towards more community-based models. And so at the previous WISH Forum, I had the pleasure, together with colleagues, of producing the WISH report on population health. And it was incredibly gratifying this morning to hear about the fact that some of those recommendations have been taken forward by the Qatari government. I think moving towards population health is a key consideration. So primary care, public health, tackling head-on the issues of prevention are fundamental. But what's also fundamental going forward is really beginning to develop an intelligence of what's happening in our health systems, and data science and artificial intelligence are absolutely fundamental to those efforts. So to help us think through those issues, I had the pleasure of working with this absolutely fantastic group of experts, and so several of them are on the panel. So David and Ifi and Ahmed have been introduced, but also in the room we have Andrew Morris, Veli Straitman, Rachel, as well as colleagues from McKinsey and Imperial College, so Giles McLaughlin and Saira Ghafour. So wonderful colleagues who together helped grapple with this, and I'm also very pleased that Annette and Maurizio have joined the panel today. What was, I think most gratifying about this was that we drew on people with policy expertise, those coming from academia, industry, and the front line. So really bringing together that interdisciplinary expertise. So as Ragay said, healthcare is lagging behind, it's straddling, really, when we compare it with other sectors. And this is reflected in our experiences. So, I mean, we do all of our banking now on our smartphones. I can't remember the last time I stepped into a bank. But our experiences of healthcare are so very different. We are still sort of making appointments, having to pitch up when quite often that care can be delivered remotely. So often we do not have access to our own records. And so healthcare is a bit of a laggard in that respect, and that's the first image that we produced in this report. And as you can see, there's quite a way for us to go if we're going to catch up with leading sectors and begin to transform patient experiences. What we also highlight in the report is that we think it is now really prime time for healthcare to begin to move and capitalize on the technological and data science and artificial intelligence revolution that is taking place, that is impacting so many other sectors in our lives in so many other ways. And there's 3 reasons that we highlight for that. The first is that there's been a lot of work done in terms of introducing electronic health record infrastructures into our health systems over the last 2 decades. And those are now beginning to mature. So for example, when I'm doing some of my research projects, I now sometimes have 20, 30, 40 million patient years of data available. That was just not the case even 5 years ago. So that's one driver. The second driver is that our ability to process and manage data and the costs of sort of undertaking that processing are diminishing, and they're diminishing incredibly rapidly. So we have this new window of opportunity. And the third driver that we highlight in this report is that there's been phenomenal developments in terms of our analytic capabilities. And we highlight issues to do with computer vision, the ability to process natural language, so natural language processing, machine learning capabilities, and robotics as 4 key components of artificial intelligence. And what's most exciting is that these technologies are now converging. So we are now, interacting with these on a day-to-day basis when we're interacting with Google, for example, or when we're interacting with Siri. Amazon is deploying these technologies. So this convergence really offers very new possibilities for us going forward. What we try to do is, and this report is aimed primarily at policymakers, is try and describe a roadmap. So no matter where we are in this process of digitizing, whether we're just in the early stages of moving from paper to digital, or actually have progressed further along the lines, so offer an entry point to ministries and governments, really, in terms of this transition, this journey towards digitized health systems. And the end goal that we hope and we think is essential if we're going to drive efficiency and drive continuous improvement in our health systems is to create learning health systems. So health systems that have the ability to continuously analyze, reflect, benchmark, and improve. And what we're saying is that what we want is these health systems to be able to do this at 3 levels. So first is at that macro level, so decision making. So when we allocate resources, when we assess burden of disease, when we prioritize, when we intervene, when we want to evaluate those high-level decisions, can we inject some data into all of those deliberations? Because so often those deliberations are data blind. Secondly, at the meso level, at the organizational level, can we move into a situation where we are continuously improving the efficiency of our operations, when we're driving forward improvements in quality and safety? And thirdly, can we actually deliver care that is harnessing some of the genetic revolution that we were hearing about again this morning, as well as, our preferences that are increasingly available through our interactions with social media. So personalized care at the level of the individual patient and deliver that care in a way that is as accessible and convenient as possible. So what we want is a learning health system that is continuously improving in all of those ways. And what we highlight in the report is that there are 5 key building blocks if we want to make that journey. The first is to understand the data assets that we now sit on. So can we get a national-wide overview of our data assets, or at least an organizational-wide overview? Can we begin to link these data assets? Because what we know is as we link data, the uses that we can begin to put these data to increase exponentially. These data are incredibly sensitive, so we need to think about the third building block here. So appropriate governance and security frameworks. We're using these data in trustworthy ways, and we can demonstrate that to the public or the publics. The fourth building block that we highlight is that we really need to develop our capacity and capability to process, to link, to analyze, to visualize, and to then use these data to drive forward improvements at all levels within the health system. And the fifth thing that we highlight is that what we want are data that are continuously reused, because this is a resource that just keeps giving. And so finally, I wanted to highlight the fact that we can begin to think about this cross-sectorally. So this is an initiative that we have been pursuing here in Edinburgh and just launched a couple of months ago, funded by the UK government and the Scottish government. And what we've done there is thought about this cross-sectorally. So we've thought about, not only health data science, but also other sectors, such as fintech, such as culture tech, agri-tech, so sectors that matter to us. And as a result, what we've said is what we want to do is not become go sort of cap in hand always to government, but what we want to do is use this data and investment in data to drive forward growth. So job creation, wealth creation, drive forward some of the industrial strategy aspirations. So thinking cross-sectorally is incredibly important. And so just in summary, what we're saying is that we are at a tipping point. We need to do things differently. What we offer here is a roadmap that we hope will be useful, and we'd really welcome feedback. We've tried to highlight some key building blocks, but the key message is that this is a one-way street. Every health system in the world will have to make this transition. And so the earlier that we embark on this journey, the better, because really the rate-limiting step is the human capacity and capability. And if we can really, take those steps early, it positions us optimally to really capitalize on that essential human capacity and capability. So thanks very much indeed. Thank you.
Thank you. Come sit down. Thank you. Thank you very much indeed for that, Aziz. And I'm going to ask questions of each of our distinguished panel. And then later on, of course, given that we've got such a fantastic turnout, there will be questions from all of you to all of our experts. But first of all, I'd like to turn to you, David. As Aziz was sort of saying, that this is a one-way road, and eventually we will all our healthcare systems that will have to travel down this road of harnessing data science and artificial intelligence. From your perch, as at Harvard, Medical School, one of the sort of most prestigious learning institutes in the world, where do you think that AI and especially personalized medicine is going to change patient care over the next decade or longer?
I think it will have a really transformational effect on the way that we deliver care. Perhaps the first place where it's changing care is in cancer care. We're seeing that already. And much of the time when somebody gets treatment for their cancer, it is really personalized to them. But we'll be using it in an array of ways, and I'll just give you a few examples. So, one is the area of high-cost patients. So, we're now accountable for the care that we deliver. And our first approach when we're taking care of a population is to identify the people who are likely to be high cost. Turns out that group, just 5% of the population, accounts for half the costs. So if you can figure out who those individuals are and then manage them more effectively, we're able to do much better from the cost perspective. Another area is readmissions. Readmissions represent a really important problem. Using techniques like AI, you can figure out who's likely to be readmitted and what do they really need to prevent them from being readmitted. Another area is triage decisions. They're very important in terms of how care is delivered. Do you admit someone to an ICU? Do you admit them to a general care unit? AI can help with that. Yet another area is detecting decompensation. So often patients get really sick before we've worked that out. If you use approaches like AI, you can be monitoring multiple parameters at the same time and find people before they really get in trouble. And maybe most important of all, it can help with managing chronic diseases. That accounts for a very large part of the burden of care and help us make better decisions. So if you're looking at someone with diabetes, what is the next medication that you should pick? Probably there are some choices that are better than others.
Great. Thank you very much indeed, David. That's very interesting. Annette, to you, I mean, you've had a lot of experience in working on this, developing personalized therapies for people with different conditions. Tell us more about where you think data science is going to have an impact, and artificial intelligence on delivering personalized medical care.
Thank you. I think it is important at every corner of personalized medicine to be true here. We heard about the introduction that bringing together the data silos is one of the crucial elements, making this data accessible, make it mine in the data for new insights, which really can then unfold such actionable insights we have heard about already. Chronic diseases is the major aspect. Oncology is one of the major topics there. It's already starting in the area of diagnosis with computer vision and deep learning assisting there in the area of cancer, diabetes, or pathophysiological changes of a brain, for example. We have also done a brain age project in this area, and thereby at the end it's lowering the burdens on the physician's shoulders. So it's really about workforce empowerment. How can we reduce redundant processes and automate them in the area of diagnostics? But additionally, I totally agree, it's about risk stratification, and not only in the context of a care. Since we are talking more about integrated care processes, it's more and more about prevention also. How can we find the right predictors and then minimize these risks for these patients in the area of developing chronic diseases? Here we have set up like risk strategies together in the area of diabetes, but it's more and more also relevant in the area of cardiovascular diseases and other chronic topics. Last but not least, personalized medicine is driven also by biomarkers and development of new biomarkers, and there, of course, artificial intelligence and machine learning can really, in an impressive way support the research topics. We are working there with the Center of Biomarker Research in Austria, for example, and it's about also gathering the insight out of the unstructured data. We have heard about NLP, for example. Machine learning itself with the NLP technology combined can help us a lot to get new insights and combine this genomic, clinical, and other data sources on our journey for precision medicine.
Great, thank you very much indeed. Ife, you work in the area where ethics and medical research and data meet. Now, when I was sort of reading this report, and I do really urge you, not just because I'm moderating this panel, but it is a really interesting sort of report. One of the things that comes out to you is it does paint a picture of a sort of a brave new world, and there will be sensitivities that all of us will have about the use of our sort of data, as these were sort of mentioning the hundreds of millions of sort of years of information that's already there that has to sort of be digitized. So my question to you is, can you build an ethical framework that can harness data and AI in medicine? Do you think that's possible?
So I'm optimistic about it. I think we can. I don't think it's easy, but I think it's possible. And I think we can break it down in, let's say, 3 areas that will help us build that framework. A lot that we worry about in data is how we protect them, how we respect people's wishes. So the whole data protection area in the digital health space and in AI is crucial. Now there, we're not doing as badly. We have new regulation. We have a lot of best practice approaches that have already been tried. And I think that area we could already rely on a lot to move on. But that's where data come from and how we use it. The second part, I think, which is important, is in the area of design and development of those technologies. And in there, some work we are already doing, and I think we have made some progress, but there's more to be done. So, and that's questions like, when you use data, let's say you have all the permissions and all is great, but you may have biased sets, or you may not have developed the right amount of evidence to show that your device or your algorithm or whatever works in the right context. So that is an ethical question. It's not just a scientific question. And that belongs to the phase of development and design. And I think the third and important phase is, let's say we used the right kinds of data for the right kinds of purposes. We developed a good product. It now has to be deployed. And in that deployment phase, again, we have ethical questions of the sort of how did we encounter, did we factored into our analysis how, for example, healthcare professionals will use these kinds of new technologies, how patients will respond, what kind of concerns they may have around the technologies at the deployment and the clinical introduction phase. So these are things, again, where we may have some indicators and work that we've done in other areas that we can coalesce and bring together in one framework. In the report, we're talking about governance as one of the building blocks, and I think that is very important, because a lot of those ethical concerns we have, we can actually address and alleviate them through good governance. And so it's crucial in moving forward and in realizing that, brilliant, wonderful possibility that we have in front of us, that governance is established, people are paying attention to it, and we don't do it after the fact.
Okay, so from principle to practice now, Ahmed. I mean, you set up and and have served as executive director of the Qatar Computing Research Institute. So from theory to sort of practice, what have been the big challenges and what's been the learning curve?
Sure. First of all, let me acknowledge the big crowd, standing room only.
Exactly.
And this is just a sign of how hip Doha is and how really...
we never doubted it.
I mean, data science and AI, and it's the topic is a big draw, and really my experience here locally, I have two remarks about that. First of all, the scientific and technical community is very progressive, and they're always looking for new and innovative solutions. Just by way of example, last week we ran a 2-day workshop at QCRI, at the Qatar Computing Research Institute, on machine learning, jointly with Big ML. We had a crowd of about 150 to 200 people that were there from 8 a.m. till 6:30, 7 p.m., 2 full days.
Wow.
We didn't lose anybody, literally. I mean, it's an amazing comment. First of all, when I talk about local issues, they're very difficult to separate from the global issues. So overall, in AI, in data science, as Efid mentioned and the previous speakers, in order for AI to be accepted as a mainstream in healthcare, we have to address issues of explainability, for example. We have to address issues of quality, data quality. We have just in conversations in this last month with some of my colleagues from Sidra Medicine, they're working on a study for preterm babies, trying to link mothers and babies' data. And in trying to devise, we were discussing jointly, devise algorithms to address how would you link these data sets and how you do identify, what factors you use to identify preterm children and so on. We realize that there are some really big technical problems that have to be resolved. So let me come back to the point of your question. We're fortunate in the sense that we're small. So Doha is small. We don't have 50 states and all the problems that you have to deal with. The players, the actors in bioinformatics are known. We know each other. They are from Sidra, from Hamad, HMC, which is the 10,000-pound gorilla or elephant. I mean, they're the biggest healthcare provider in the country, so they're an important player. And then we have the research institutes. Sidra also has the research institute, the Qatar Biomedical Research Institute, Qatar Computing Research Institute, and we all have elements of folks that are doing bioinformatics, and we come together very, very easily. The last point is we also have the Qatar Genome Program that you've heard of, the Qatar Biobank, and the data custodians at Sidra for the Qatar Genome Program. So these sort of the electronic health record in the healthcare arena, and then in the research, the genome program, the genetic data, and so on. These things come together much more easily here than in other places. The one thing that I believe we need to work on more, in addition to the issues that the others mentioned, governance and so on, everybody has to work on that. We are maturing, but we're not totally mature yet when it comes to policies for data sharing. And this is just natural because we're starting and we're figuring those things out, and we're breaking some of those barriers to sharing data so that we can work together more easily. And I'll come back to this through the conversation later.
We certainly will. We certainly will. Thank you very much, Ahmed. Maurizio, you've worked in research and technology, but you've also helped to give life to a number of sort of startups. So my question to you is, what are the key policy levers, if you like, for governments and countries in order to really drive this sort of potential forward for data science and AI in healthcare?
So I'll take a step slightly back from your question, which is, the realization, and I think it was addressed in our keynote, and it's certainly well addressed in this document, in the report, the fact that we are in the middle of not one, but multiple scientific revolutions. So data science, big science, and artificial intelligence is certainly one, but it lives in a context where genetics and the genome revolution is basically still beginning to unfold, let alone reach its maturity. And other areas, like, for example, advanced and next generation diagnostics, are all converging into an integrated healthcare of the future, which is dramatically changing where healthcare needs to be provided, when it needs to be provided, by whom, including the role of the patient at home. So imagine a world where the wearable devices are not just toys, they're not just sports medicine, but they are becoming critical parts of your healthcare. Imagine a world where the data being originated is so massive that unless, from a policy perspective, governments and institutions start really handling the data in that sort of convergent, interoperable environment, I think we're at the cusp of seeing new medicine being discovered when you go from point treatment, point diagnostics, to continuous monitoring and so on. And chronic diseases and non-communicable diseases are clearly a place where you can start seeing that already. Cancer care has been mentioned, cardiovascular and so on. But there's also a lot of conditions that currently will take a patient to the hospital or to secondary and tertiary care that probably can be triaged or managed much more effectively at home and in primary care, which is why we go back to primary care being the foundation of where we're heading. To me, all that is revolutionary. And it's a convergence of both technology and scientific trends, but also policy trends, because essentially these data sets are going to become national assets, maybe even international assets. The discovery of tomorrow, from therapeutics to diagnostics, are probably going to come by looking at this kind of data. But guess what? The data belongs to the individual.
Yeah.
So this grand bargain needs to emerge between individuals, governments, and private sector. And you asked the question about the private sector. It is revolutionary what the private sector could do if these data were curated and institutionalized. And that's going to be the key enabler that I think government has to take into a role.
Okay, we're going to throw questions to the floor in a minute, but I just want to follow up on that point and ask all of you very quickly going round. I mean, you raise this kind of revolutionary prospect and the impact that this could have on governments, okay? But the worry is, looking at what's happened in social media, this data is private. I go back to, in some ways, what Ify was sort of talking about. Do we not need to work that bit out first? Do you see what I mean? Why don't you go, since you've got the mic?
Well, I was going on Ify's comment. From a technology perspective, maintaining privacy and creating the right framework is not unknown. As a matter of fact, there's lots of emerging techniques and real techniques to do that very well. It really is sort of a policy grand bargain that needs to emerge between the owner of the data, the patient, the aggregator of the data, maybe government, and the exploiter of the data, maybe private sector. I was talking the other day to somebody who suggested in the future, just like you enroll in a clinical trial, as a patient, you enroll in a clinical trial, and at that point, you're expecting free access to that care. Maybe in the future, we'll all decide to contribute our data, and in exchange, we're using that as the currency to pay for our healthcare. I don't know. There's lots of interesting possibilities coming out of that, especially if you assume that the data set is valuable not just to manage healthcare better, but to do new discovery, new treatments, new diagnostics. So it's an interesting possibility.
Ahmed, very quickly.
I was just going to come to patient intent, which is something that we spend quite a bit of time talking about. As patients or donors of samples participate in studies, how do we keep the original patient intent in mind? That is, the conditions under which the sample was given, and as we progress on. The other comment is it would be great for technology if it was able to integrate patient outcomes. This is an area where healthcare, in my opinion, I'm the furthest away from the practice. It's an area where we fail quite a bit in. That is, how do we integrate patient outcomes into the equation? And Effie and I were sitting there and we were talking about an example of an accident that happened a year ago in Greece with the fire. And if it was just there was a feedback loop, a lot of those 100 people may have not been killed in the fire. So,
okay. Effie, very quickly, I'll go around three, and then I'll come to Aziz because he wants to jump in quite quickly. Go ahead. No, you go first.
Okay. No, I think what we see, which is very optimistic again, is that in every survey that's been done, when we ask people, would you like to donate your data for scientific purposes, for the to improve understanding about health and healthcare, we get the majority of people, overwhelming actually majority of people saying, yes, of course we want that. So I don't really believe that the people, all of us, will be the obstacle to sharing our data for our common good. But what we all need individually and in the collective is that we're respected then for that choice. So that donation of ours or that willingness of ours to contribute to the common good, it doesn't turn around and used against us. And I think, I don't know how it's in Qatar, but across the board of surveys that I've seen globally, we see that people are willing and want to share to contribute to that common good.
Yeah, just to answer your question, there was quite a bit of debate and a lot of discussions that were run and managed through the Qatar Biobank as being sort of they're the original custodians of the samples, to work these issues very, very thoroughly. And I was very, very impressed by the depth of respect for these concerns here.
So I personally totally agree. We have to add, of course, value to the patient at the end, and he has to get a feedback of the outcomes he's delivering. They are often accepting data for research in this context. Of course, the consenting has to be transparent, and it has to be a compliant and reliable way. But I definitely think if they get back value and also a campaign, an education program where they can believe in, where they have a transparent approach to see what is happening with this data within the healthcare journey, this will be a success.
David?
Yeah, I think the key role for governments and for policymakers is to enable aggregations of data like the ones that we're talking about that should include outcomes. It also has to include appropriate safeguards. Most of the frameworks that we're using were developed 20 years ago, before a lot of the things that we're talking about now. So we need new frameworks.
Okay, Aziz next, and then there'll be mics roving around. So get your questions ready, and I'll go to the floor. Aziz. Yes. So can I just ask you? I mean, just as a sort of. one of the things that comes out of this sort of report, it's great, it's very exciting, but you and Ahmed mentioned it, the importance of taking the public with you, and how much of that, and how much of it is hype as well.
Yeah, so I mean, as we're putting this report together, we aimed it primarily at policymakers. And what's crucial, I mean, I think we're learning from our experiences, is that engaging with the public in mature discourses around this is incredibly important. So they need to know, I mean, the way these data can be used, and there's myriad of ways these data now can be used. But I think we also need to think about this in a proportionate way, because not all data are the same. So there are completely aggregate data which, from which you can never be, individuals never be identified. And in those cases, I mean, I think it is this sort of public bargain or social contract that applies, and we need to talk about that. But there are other data where, I mean, there are risks, and I think we need to, I mean, spell out those risks, give people the opportunity to opt out, and then do whatever we can to mitigate against those risks. So, for example, when I'm working with census data, which are linked with health data, so these are some of the most sensitive data available, and we do this under, I mean, researchers do a check, they have criminal record checks, we have video surveillance, we have disclosure control committees, they're working on dummy terminals. So we do everything possible, and I think we just have to have a much more mature dialogue around this than thinking all data are the same. Okay,
that's very interesting. Okay, there is a gentleman there who has put his hand up, and then this lady here. But go with the lady first, and then that gentleman next. Do stand up when you ask your question, and say who you are, if it helps.
Hi, very interesting discussion. I'm Dr. Neeti Paul. I'm the Global Medical Director for KPMG. I'd just like to turn the debate around on its head slightly from a patient perspective. I was in San Francisco recently with a bunch of patient disruptors with the hashtag We're Not Waiting. These are type 1 community who've hacked their algorithms from their CGMS and connected it to their pump. They've got 4 artificial pancreas systems going now, and the first med device companies partnered with Tidepool to make this happen. So my question to you is, I think we've talked about data and data protection. My question to the panel is, how are you going to harness the power of the consumer, the patient, to actually drive some of the stuff that we're talking about to really achieve some fantastic new developments in healthcare?
Very interesting question. Okay, I'm going to go with Maurizio first, and anyone else just jump in, because all of you could have something to say on that.
This may be a good time to have the discussion about the hype versus the reality. Not that what you're saying is hype. But understand that the word artificial intelligence is probably a misnomer. It should probably be called statistical intelligence. So what you have out of the modern machine learning systems is the ability to establish correlations. Correlations don't always mean causation. And so one of the big transitions that I think our field needs to make is to go from getting a bunch of data, trying to establish correlations in that data, and then come back to what does it mean from a clinical and a medical perspective. That is why the comment that was made earlier about clinical outcomes is so important. I can tell you I have 2 programs that is interesting to contrast and compare. One involved following patients for 10 years with clinical outcomes, and another one is just a bunch of data. And our earth-shattering breakthrough discoveries that came out of the one with the outcomes cannot be compared with the correlations that came out of the other things. So there's data and there's data, and how you curate that data becomes critical in driving forward the algorithms that, and you don't necessarily need to have new algorithms if you have the right data set. And so curating data becomes a very important aspect of the future evolution of this. And so we think that while the big tech companies are going to deliver better and better algorithms and more efficient computing, what they're not necessarily going to deliver to you is that curation of the data set in a clinical setting that then drive the real discovery and the real breakthrough. And I think it is the job of the clinical world, it is the job of the part of the academic world that has the clinical connection and the population of patients to participate in that. And the example is, again, you know, this watch in theory can tell me all sort of things about my heart, It even has an FDA clearance for it. But the reality is the data that you get out of it from a clinical perspective is at this point very minor. So don't get too carried away in thinking about the future of the crowdsourcing aspect, because you can get a lot of correlations out of it that are not clinically actually significant.
Ify, anybody?
I just quickly to jump in and say that I think there is potential, and I like that you brought that up. There is potential, but we don't have some good systems of harnessing that potential from, and ideas from the citizens, from the patients themselves. There are some isolated examples and cases which I think should have become more mainstream than what they are. I do still think we see patients as data, as repositories of data that they're going to give us in the field so we can do our things. But there's a lot of potential on the other side with ideas and projects. So actually, I'm glad you're saying this. I think there's a part of it that's high, but there's also a gap in how we integrate that power into the systems that could help us advance.
Anna, very quickly, and then I'll go on to another question.
Just a short comment. So on the technical side, of course, this is happening. There are patient engagement platforms engaging with the patient, collecting remotely electronic patient-reported outcome. But of course, it needs to be a relevant patient outcome. Yeah, we need also from a clinical area define the surveys in a way that it is really relevant for the patients, and therefore, on the whole cross-sectoral collaboration, we need, of course, to engage with the patient overall in a tighter way. So there are public-private partnerships aiming for these reasons within Europe and within the whole world. But yes, the patient needs to be put in the driver's seat from the very beginning. The other project I can mention here is maybe a project driven by the National Center of Tumor Diseases, where there is a virtual room for the patient to share his data with the physicians and the feedback with the physicians along his care journey with the center and also the GA practices around him. So there are different initiatives on the way to embedding the patient more and more into the middle of our solutions and digital approaches, but we can, of course, speed up there.
There's a gentleman there, and then afterwards I'm going to go to the gentleman there.
Yes, thank you. My name is Bob Thomas. I'm a surgeon by trade, but the last 5 to 10 years have been advising the Australian government about health matters. I've just been dealing with a large linked data set. And as I was listening to the fantastic conversation here today, I sort of thought that maybe there's two sorts of AI. There's one is what Dr. Bates talked about, which was getting an algorithm out of a confined set of data to try and get a specific clinical objective from that data. Then there's the data set, which Dr. Sheikh talked about, which was a massive data set. And what I'm asking is whether AI will ask the questions or provide the answers out of those data sets.
Ahmed?
Sure. So, unfortunately, the problem is even much, much more complicated than that. You get a data set in the input, and you want to do analytics on it to be sort of machine learning type algorithms on it. From that point to the point where you can actually start doing the analysis you're talking about, there is a huge life cycle. You curate the data, you've got to clean the data, you've got to discover the data sometimes. And in fact, we now have a project working with Merck trying to discover data out of 4,000 Oracle databases each with hundreds of tables and so on and so forth. So the real world isn't this thing that we read about in the newspapers with general AI and this magic. It's great because it's getting people interested, but the type of AI we're talking about here is narrow AI, that is sort of solving mundane, simple problems better using large amounts of data. This life cycle that I talked about, sort of discovering the data, cleaning the data, deduplicating the data, lining the data up properly so that you can start running meaningful, whether it's deep learning or any type of learning algorithms. This is where what we call the grunt work is, and this is sort of the work where computer scientists live. So it's not flashy and rosy as we think it is, and you know, in the movies, even though we enjoy the science fiction, but it's the kind of thing we're talking about is sort of very, very mundane.
Mundane. David, do you want to go ahead?
Yeah, but here, of course, data management platforms and the new digital approaches can, of course, help to speed up the integration of these different diverse data sets. And, of course, there are more and more solutions like data quality dashboards and so on, which can help to curate this data. And if we then once reach the state that we say data quality is, in our point of view, acceptable, then of course it can be different flavors of machine learning and also complex models which can be applied to it. This depends on the volume of the data and also on the complexity of your question you want to ask to the data. And sometimes you ask the question, and sometimes you do not supervise the machine learning algorithm. There are different models available.
Yeah, and the point I'd make is just that knowing about some lateral factors, like, for example, what the weather is, can be very predictive of all sorts of things. So, for example, you can predict how many people are going to show up in your emergency room with fractures based on what the weather is. That's not the kind of thing that we're doing today.
Maurizio, you want to jump?
Yeah, I just wanted to say, in the realm of possibilities, I gave you a cautionary note in my prior comment, but in a world where you have a perfect data set, and that's a set that is large and has outcomes, we've actually discovered that the machine learning can teach the human something about medicine that was previously undiscovered. And we've had a number of examples of that in our current effort. So you could think about a future where the data set is clean enough, large enough, has the outcomes that are relevant, where you could actually start thinking about discovering some new things. And actually part of our effort in that particular example has been to try to understand what the machine learning algorithm is looking at so that we can come back and actually develop some new medicine. So possibilities exist, but we're in the infancy of all that because it's very rare to have that kind of data set.
Okay, there's a gentleman with the mic there, and then another gentleman at the front and over there as well. Go ahead.
Hello, my name is Ricardo Leite. I'm a member of Parliament from Portugal and also the head of public health at the Católica University in Lisbon. Thank you for this interesting panel. As a policymaker myself, I feel that you've written this for me, so thank you. And I have to say that I think we're speaking to converted here. We all believe that this data science and AI will help transform not only individual health, but also public health and health system management. And even in terms of leveraging research and even in terms of clinical trials, we'll be able to empower them further. However, when it comes to policy, we need to do more. And we cannot continue to create another framework that will be outdated 5 years from now. We need to create frameworks that will be nimble enough to be able to adapt so that policy is not always a step behind. The problem is most policymakers are unaware of this discussion. And so that's the first barrier. I couldn't agree more that the people are not going to be the barrier. Normally it's the politicians that set up those barriers. We've seen this in Europe by creating an opt-in system when it comes to data sharing. And that is a mistake. So the first question I leave is, how do we generate regulations, and how can the whole of the community and their multiple partners create proposals in terms of legislation, not just recommendation, concrete law that can help us move forward in this direction? And secondly, being so important as it is when it comes to using AI to help decision making, shouldn't we also consider it to be under a framework of health technology assessment or some kind of auditing, in the sense that we make sure that everything that produces a hypothesis or a proposal for treatment makes sure that we're getting what we're bargaining for? Thank you.
Thank you very much indeed. Well, there you are, a real-life policymaker, an MP from Portugal. What do you have to say, Aziz? Because you did write it for people like that gentleman.
So thanks for the question. I mean, I think what we're... So, let me just reflect on what we've been doing in the UK. In the room we have Andrew Morris, who's the Director of Health Data Research UK, which is a new national institute that we've created to try and really push the boat out in this respect. So think about our data assets, engage with national leaders, engage the public, begin to try and get our data assets on the front foot, because so often we're not thinking about the data catalogs and the data standards. And can we actually move this discussion so we are on the front foot and thinking proactively about trying to being able to maximize the utility of these data. I think what we also need to do is create these conversations between ministries of health in different countries, because quite often countries are grappling with this by themselves when others have taken a step down the road. That may have gone right or wrong, but there are lessons that can be shared. So can we increase that opportunity for cross-country dialogue in that respect? In terms of bringing AI into the realms of health technology assessment, again, I think there is movement taking place in that front in several countries, because these algorithms have the potential to benefit enormously. We've been hearing about that, but there are some risks associated with these algorithms as well. And so we do need to ensure that these are carefully scrutinized before they're deployed at scale. So there's appropriate derivation work, validation work going on. And as they're put out into the field, that evaluation continues. So, I think there is a lot that we can do, but if we do it in our siloed ways without that cross-country dialogue, I think we'll be missing a major trick there.
Do you think, just to elaborate in very simplistic layman's terms, the question the gentleman was asking, do you think, in this report it's quite clear what data science and AI can do, but for politicians it is the bottom line, what does it enable me as the policymaker to deliver? How will it change the health system that we have for the moment? Does it mean more efficiency, more money? Do you think you've explained that enough to government? Do this, follow this road, and this will be the payoff?
So maybe I'll just kick off if that's all right. So, I think some of this is about the time frame and where you are in this journey. So, for example, in terms of driving forward research and innovation, this is the low-hanging fruit. I'm seeing some of my research costs when I'm working with these routine data that are now available and mature and are linked. Those research costs for me are plummeting by something like 90%. So we're driving forward orders of magnitude change. So that is the low-hanging fruit. Down the line, where we are taking national policy level decisions, and if we can then evaluate those. So let me give you an example. So we are, later this week, we'll be publishing our report on the evaluation of London's low emission zone to try and improve research air quality. So we have then feeding that information back to policymakers to allow them to think about what are the next steps that need to happen on the back of that. Now, those things go unevaluated. They're kind of major spend on the public purse. And if they are not working, we can actually draw a line under those. Ask policymakers to think differently. So it depends on really where we are in the journey. And I think, the other dimension here, and I only mentioned that briefly in my presentation, is that this is where job creation is coming from. As a result of robotics, we're seeing, and we're going to see this in our hospitals. So we'll see, so many of our kind of driving related jobs in health systems eradicated from driverless vehicles. We're going to see robotic porters, cleaners, cooks, check-in desks. So, there's going to be a lot of job losses. But when we look at job creation, at the moment, it's all in data, really. It's data processors, data linkers, data visualizers, creating the dashboards, and then, of course, the analytic piece that goes with that.
Okay, interesting. Ahmed, do you have something to
add?
Also,
I was just going to acknowledge the Honourable Member of Parliament from Portugal in the sense that auditability is very important. If data and decisions cannot be audited, then we're never going to get it really in use. And there's some technical problems that have to be solved to be able to deliver auditability. One of them is provenance. So database systems and data systems in general ignore the problem of maintaining lineage or provenance of the data. We have to be able to keep a record, keep track of all changes that happen on the data in the data life cycle. And so there are some technical problems before, and I want to hear what Effie has.
So, yeah, these are valuable comments. I think they reflect the tension we're seeing, that we have a very fast-paced technology. So we have the fast and the slow, which is how we legislate. We create rules slowly, so by the time they're there and effective, they're a little outdated, as you pointed out. So I think that is one problem we have. A practical suggestion maybe to this is also, so for that we need more agile systems. So we have the legislation, but then to me it seems that best practice could get us further than the hardcore regulation in some areas. And there is where I think we need to be making more investment. What is best practice within the broader frame of the law that we can also change frequently as our needs change? And perhaps the third point here is, what I see at least is when we talk to policymakers, is there is really a gap of expertise. We have the very technical people, we have those responsible for policymaking, that they need to understand suddenly very complex and fast-moving technology. And there, the practical recommendation maybe is that this dialogue, this expertise, the technical expertise, has to be also in the policymaking domains. Otherwise, we'll end up making policies for things that are going to affect us all without having a basic understanding, or at least a degree, understanding of the degree of complexity.
Okay, very quickly, Marcia, because there are lots of questions.
And a corollary to that, which is one of the levers from a policy-making perspective, is the regulatory posture. Really, the regulators don't know how to regulate these new technologies. Even the most sophisticated environments within the regulatory environment are just doing the kind of technical empowerment to try to deal with learning machines.
Right.
So think about the regulatory posture at the country and EU level and others.
Okay, I'm going to get through these questions a lot quicker. This gentleman there, then this gentleman at the front afterwards, then we're going to go to that side. Go ahead, sir.
Okay. Thank you very much. I just wanted to comment on the feelings of people here who were polled about the improvement or lack of. People seem to have a negative negative feeling towards AI. Anyway, my question was specifically about diagnostics. If, for example, the cycle from new research to the field is going to be impacted by AI, the question is, will it become faster? And if this becomes fast enough, very fast, from the moment something is, becoming the best practice to the need to have it applied in the field, would that mean that people who are doing the diagnostics will now have to deal with a wave of a lot of new changes in, for example, how they should interpret or diagnose what is happening? So these systems maybe can play performance support, or will they be able to actually help make the decisions? Will the diagnostic process fundamentally change because of the complexity and rate of change that will happen? I haven't heard specific, because artificial intelligence is about agents making decisions rather than just deep learning. Thank you.
Annette, do you want to, it's on David, go on.
Yeah, I think it is likely to change fundamentally. I mean, one of the biggest safety issues that we have today is diagnostic errors. That's a problem that's been relatively resistant to change, but I think AI could help us a lot in that regard with respect to coming to better choices, to more fully considering what all the options are, and so on.
So I think personally diagnostics is continuously changing also on the technical side, not only the software side. Think about liquid biopsies and whatever is dropping into the research and clinical area. So it is a direct, continuous change there happening, and we need to adapt there as an expert for diagnostics also. At the moment, I think, as you have said, artificial intelligence primarily aims for a collaborative scenario, assisting, speeding up, helping to prioritize. You have also said it with which patient is maybe in a risk of readmission, which patient has which risk of mortality, or which patient or at which image area should I look like as a radiologist, more in detail and concentrate on. So this is the actual state, I would guess. Nevertheless, I would expect that artificial intelligence in the future offshore will change diagnostics. And FDA is approving artificial algorithms more and more, and the European Commission, I was visiting them last week, they are of course also think about how can we involve experts, technical experts in our steering committees to make these technologies also in the area of drug development and so on, where wearables are used more and more as diagnostics and software as more and more a medical device. How can we then, of course, make the proof point or the check of the studies at the end? And study design in this context has also to change.
Thank you very much. Go on, sir.
Yeah, and this is a slight digression, but the reason why, from a Gates infrastructure perspective, we're making a bet on next generation diagnostics combined with artificial intelligence is because it provides not just a better diagnostic, but it can provide decision support to clinicians that may not be your top specialists. So imagine a world where, through the help of these decision support mechanisms, a primary care physician or a non-physician clinical provider can make decisions at almost the same level as that expert. And everybody will be an expert in the future if we do this right. And it's not just about the artificial intelligence, but it's the artificial intelligence interacting with those other molecular and other type of diagnostic technologies that are also in the midst of a revolution, so that you provide the clinical inputs to the algorithms to make effective decisions. And we think that's going to be very real. And ironically, the developing world may leapfrog the first world because they don't have the existing infrastructure that stands in the way. And so we are watching experiments in many low resources countries where the quality of the decision support and diagnostics through these technologies might actually leapfrog first world settings.
That's really interesting. This gentleman here, and then there's that gentleman in the blue shirt afterwards. Go ahead, sir.
Salma Rawaf from Imperial College London. Thank you very much for the excellent debate. I have absolutely no doubt patients at level of care will get a lot of benefit from artificial or statistical intelligence. We have no doubt about that. The question is, what's about people who don't have any access to health care? I mean, currently we have about half of the world population. This is recently announced at Astana by WHO. Don't have any access to any health care. What would be the benefit of all this discussion?
Go ahead, Ahmed. Jump in.
I mean, I would imagine that telemedicine would be, having access to the world's best physicians through a television remote access could very well be.
Yeah, and what I just told you, I mean, from the perspective of the world's largest charitable trust, heavily involved in the 137 countries that are the poorest in the world, we see this as an opportunity to leapfrog healthcare delivery. So we're gonna bank on these technologies to make healthcare access democratized and cost and affordable without compromising the quality by leveraging these technologies. So that is a deliberate strategy. It's a bet. We don't know yet if we'll be successful, but that is the intention.
Aziz.
So just very briefly, I mean, I think what we're going to see is the focus so far has been on provider-level decision support, but I think we're going to see an increasing focus on patient or consumer-level decision support, because even in these environments, smartphone penetration rates are very high quite often, and I think that's going to be an enormous area for growth going forwards.
This gentleman there, and then this gentleman, and that lady, and then that lady. I'll remember it in order. Go ahead. Oh.
Stephen Dorrell. I'm another, in my case, former Member of Parliament and Health Minister. I now chair the NHS Confederation in London. I think it's a very good discussion, but there's a point I want to make which concerns me to a significant extent about this discussion of data in the context of health. And my concern is that if we're not careful, we entrench the silo of health rather than taking the opportunity to look beyond healthcare systems to the wider determinants of health. Quite likely, in this conference, there's a discussion here about the application of data within a healthcare system, and in another room somewhere else, there's a discussion about the social determinants of health. Maybe data is the opportunity to break down those two silos so that we recognize the interrelationships. We recognize that we're all of us citizens first and only patients second.
Thank you very much, Stephen Dorrell. Do you want to go on that?
Yeah, so I'm happy to respond. So, I mean, Stephen, in the report we do talk about cross-sectoral data because what we're finding is that, I mean, as we link our health data assets with education data, pollution data, unemployment data, socioeconomic data, I mean, the uses that we can begin to put these to understand disease and also to think about how to intervene just increase exponentially. So, I mean, I think you're absolutely right. And when we're also thinking about the growth agenda, we need to be thinking about data in the round. So that cross-sectoral data thinking, I think, is absolutely crucial going forward.
Evie?
And I agree with you entirely, and I think it might provide a further opportunity, which is not only to understand, to increase our understanding about the social determinants, which we may know already, but also to have interventions that they don't look like just health interventions, but they are digital type of interventions that can have a direct impact on health outcomes. So I think it is a great opportunity to do precisely that.
Great. Gentleman here at the front, and then lady there, and then this lady here. Go ahead.
So Andrew Morris from Health Data Research UK. Terrific discussion and terrific report. So I helped write it, so it's good. I have a question about business models. So if this is going to be sustainable and scalable and move at pace, then we're going to need industry to work with providers and academia to make it work. What we're seeing in the UK is an influx of big tech companies, often signing bilateral arrangements, often on an exclusive basis, which actually will conspire against data sharing at scale. So could you comment on trustworthy methods of doing business, because this will be monetized, and also our evidence from the UK is that people expect a benefit share in a trustworthy way, which mitigates against excessive profit making. So I think business models is an important issue.
Mauricio, do you want to talk about that?
Sure. Well, let me first of all say that there is no magic formula, at least in our experience, to do this. Obviously, we are a foundation that is trying to stimulate commercial activity in this sector. We can leverage a very large financial commitment, which is similar to what governments can leverage. And so there are some learned lessons there. One of the things that we started doing is focusing on that translational place, where you're going from academic research, typically funded by the usual sources that fund academic research, to product. And there is a place in the middle that is typically unfunded. The biotech industry calls it the valley of death. But that is a place that if you can bring non-traditional players, not government necessarily, but for example, private foundations, you can instill best practices around, say, data sharing and data policies at that stage that then carry into the product. So that's a lot of what we've been trying to do in our relationship with the private sector. We essentially ask them to look at interoperability and to look at openness of data for the greater good, using the power of our dollars when those same private sector players want to access those dollars, and before they become so profitable that they can forget about our constraints. Okay. And maybe that's a model for governments.
Effie and Ahmed, Effie, do you want to go?
I'm just going to quickly say that security, data security and data protection is also essential to keep citizens' trust. Every time there is one of these breaches, we sort of go back and lose people's trust in these types of things. I think technology is not the easiest, but it's not the obstacle. The obstacle is trust, is privacy, security, ethical issues, and these sort of policy issues, regulations, and so on.
And perhaps another point that relates to business model is intellectual property, right? We have to we now build business models on a certain intellectual property regime that we've seen has done certain things well and certain things not so well in healthcare. So the big question for me would be what kind of intellectual property regime we would need in the data kind of world we live in that could promote the kind of stuff we're thinking about. And that question, I mean, some players are addressing, but it's one I think that is maybe the elephant in the room sometimes.
So I totally agree that also rethinking of the business model process is completely needed, and this is happening already. So what I am engaged in is, of course, research projects which are primarily funded, for example, also by public initiatives. But then, of course, the level of sustainability is questioned, and then often there are also new business model in place where the reimbursement of a health insurance and so on is coming into the game. So I'll give you one example in the pre-diabetes area, which was developed together with Roche from our side, where a risk stratification of pre-diabetes patients were established, and we managed together with this e-health technology to minimize the weight and guide them in a loop with physicians there and experts to address their challenges and minimize the risk of diabetes. And this was then established and pointed out in a study. You always have to prove the endpoint. And then, of course, you can come to the level about how can we then financially support this? Is this a service which is then paid by insurance? Can this be a new business model process? And what are the stakeholders which will contribute? Just to give you one example. Okay. And more of this cross-sectoral collaborative approaches and cross-sectoral business models are also popping up with insurances, pharmaceutical industry, and providers coming together and think about how can we share value and also set up collaborative business models.
David, very quickly.
I would just suggest that many of these data sets represent a public good, and that if you put them in place, then industry will come. Places that have tried to charge a lot for them, it hasn't worked out so well.
The lady at the back, we're in the last 10 minutes. I know we could go on forever, but last 3 questions, but make them short and I'll make sure these guys are to the point as well. Go ahead.
Thank you very much. Nina Modi, Professor of Neonatal Medicine, Imperial College London. It's a great conceptual discussion. I run the UK's National Neonatal Research Database, which is used for policy, research, drug development and evaluation. And I'm in the process of developing an international neonatal research database. So my question to the panel is, what global forums are there for addressing, first of all, regulation, secondary, patient confidence, intellectual property, on an international level? Are there any tangible forums for addressing these issues globally?
If that's your...
Well, I wouldn't say maybe a forum, but a lot of international organizations are trying to tackle some of those and take some leadership roles. So the OECD has done and is doing some of that work, for example, on regulation around data sharing and data access, not as much in at least the parts I know on intellectual property. There's been some work that's done by the World Health Organization, again, taking an international perspective and providing some sort of guidance and how we can move on in practical ways. So these at least two organizations, I believe they're providing opportunities, but if you're thinking of a forum of debate for all partners, that might be something we have to think more about. That one, I don't see. Maybe David knows or not.
No, I mean, I would just say you're bringing up something that's a good point. We do many things that involve international collaborations, and things always get muddy very quickly when we get into that space, and I don't think there is a good forum today.
So David, you may want to mention this ministerial level summit that you convened through the Commonwealth Fund, where we began to grapple with some of these issues.
Sure. So we had a ministerial summit a year or two ago now, in which we brought together the health ministers from most of the developed countries and did try to bring up some of these issues, and that was a good start on this area.
Okay.
I'll also give a shout out to the effort that WHO and the ITU have convened around AI for Good, which is now an annual event. And the ITU is taking a role on behalf of the WHO to begin to look at these issues and create sort of actionable policies. Infancy, but there is an effort, and the last AI for Good had representation from almost every country in the UN, so it was a pretty significant effort.
Great. Okay, and there's this lady here at the front.
Hello, yeah, you can hear me. Fantastic discussion, very excited to be hearing all this and all these different perspectives. I'm in Joe Howell and I head up clinical operations at Sanofi. So it's good to throw in the pharma word in this conversation as well. So at Sanofi, we do pride ourselves as being a committed healthcare journey partner, and we are utilizing AI and data science, in the company for developing smarter protocols, smarter study designs, and that significantly, demonstrably accelerates access to the medications for patients. What I wanted to really understand, and we touched on the GDPR, that's cited as in 20 years the most significant change in data privacy. What I really wanted to, I guess, get your feedback on is from my perspective, is bringing that level of innovation to this region, and grappling with maybe perhaps a lack of expertise or full understanding of exactly what we're trying to achieve. Let's give an example of harnessing big data, electronic health records. What could you comment or say about pharma's involvement in being a partner in this innovation, and to be able to mutually benefit and actually serve our commitment to nationalized understanding of the requirements, which is then the building block of, total universal healthcare, if you like.
Involvement of pharma in this sort of journey.
So maybe I can shortly state about where I see pharma as a major stakeholder in the area of big data. So what I know, there are initiatives where pharma, even in the area of lead identification in a pre-competitive way, share big data to really make pharmacogenomics and pharmacokinetics in a safe and secure way understandable, and learn from this data in a collaborative way as one big pharma industry on a very early stage of drug development, as one example. So I think there is a strong responsibility and a unique opportunity for pharmaceutical companies to harvest this technology. Think about 3D imaging of cells and how you can assess pharmacokinetic processes within the cells at the moment, driven by artificial intelligence also. So yes, we have to say that the responsibility on developing safe and secure drugs can learn from or can use artificial intelligence in a very efficient way. But then, of course, bringing this into clinical trials and to the market at the end, there are different stages which have to foster these new technologies maybe more in the future.
Okay, who wants to? Yeah, go ahead.
Very briefly, I mean, pharma as a traditional actor in this space, I think, has an incredibly important role. And just alone by, being the good citizen when we're talking about data access, I think this could make a huge, it could help hugely to promote the area. EMA, the European Medicines Agency, has and keeps inviting pharma into the process of data access. There are new policies, Policy 70, that pharma also has contributed, that will help very much the part of data access and sharing, which I think is the building block for developing that further technology.
Very quickly.
And I'll say just 1 second. There is a tremendous amount of pharma-generated data around targets that have failed, and those are hidden. There's a lot of benefit if we could get access to all of that.
Okay, one last question. Make it quick. There you are. It's working, I think.
So I'm Ahmed. I'm a Dr. Ahmed. I'm not a scientist or politician. I'm a physician, head of a rehab department and head of quality department at my work. It's a very interesting discussion, and I have sort of an interest in this, but I think in a way, I don't know, I would like to ask you, at this moment of time, you are asking politicians to drive the change, and I will not be happy to give my data to politicians. I believe in liberal world. I don't know why I need to give my data to a person. I was very keen to hear more about how my life will change. What do you want me to do? Will you make me live longer? Will you make me feel?
Very good question.
Are there very real?
Okay.
I mean, you need to drag me to do your work. I don't want to do it if you want to force it on me.
Okay. How's it going to change people's sort of lives? Paint a sort of picture very quickly, because I'm being told we're sort of out of time. Who wants to go? David?
I think it'll help you live longer, help you feel better, give you suggestions for you about which things you should work on.
Okay. Anybody else? Ahmed, do you want to jump in?
Well, I would just say that the future is really, really bright. So technology and the thing that we have, the potential at least, of the things that we could look forward to that would happen in innovation related to AI are tremendous. We're literally just scratching the surface. Where AI has done really, really well, like things related to image processing, computer vision, language, speech, and so on, there are gazillion other technical realms and applications where AI is still very, very at an infancy stage. So the potential that I see is tremendous, is really, really bright, and I can't imagine being in any other field than computer science, artificial intelligence, and data science for the next 20 years.
Aziz, I was going to make the gentleman live longer, help him do his job better, maybe even get him to feel good about giving his data
David's
to a politician.
guaranteed sort of a longer life, and you're going to be happier, and maybe you'll find a better partner as well. I don't know.
Okay, we have actually got time for one last question. We've got a few more minutes. There's a gentleman there standing up. Could you give him the mic?
Yes, thank you. Great discussion. I'm Dietmar Frey from Berlin. I'm actually a neurosurgeon, but I'm heading predictive modeling in medicine. Actually, we are dealing with stroke prevention and treatment, and we are using AI. So I wanted to point out a very important question for me as a doctor also, and you touched upon. I think outcome is important. So it's the crucial point, and not only for AI and machine learning, but only for a general view on medicine, actually. So I cannot understand why we don't, also from policy side, really enforce outcome to be on the top, to be the top priority of medicine, actually. Of course, I came upon that because we don't have enough longitudinal data, but still this is actually a major it would have a major impact, not only on AI and machine learning, but on the whole system. So that's what I don't understand. I just wanted to know what's your opinion on that.
So I totally agree. Value-based medicine needs, of course, also outcomes to evaluate at the end the value. And I see a few initiatives where with a lot of efforts, people collecting outcome data and add this to their database at the end to enrich the measurements and to make valid insights out of this data. But it's only a few, and itself by the definition about which measure of outcome is relevant to us, the opinions are different. So interoperability and standards and a definition of the outcomes, and then of course a regularly documentation and assess of these outcomes, if it is with wearable technology and patient-reported outcome, or if it is with other ways like telemedicine or whatever, to follow up with these patients in a regular way. This is a new domain to precision medicine also, because a precise therapy means also a tailored follow-up strategy, and we should aim for it. I totally agree.
David and then Maurizio.
We're making a very big investment, in particular in patient-reported outcomes, so that when you show up at one of our clinics, you're handed an iPad. We collect data from everybody now, and I think that's going to be the way that things will be done in the future. It'll be really valuable.
Mm-hmm. And I think one of the issues, so first of all, it's clear that the outcome data is critical, but one of the issues is that often it's buried inside clinical trials, and it's not necessarily, those of us that sponsor clinical trials should make it a point to not only curate the outcome, have the right gold standards in that outcome, so that you're not introducing statistical errors, and at the same time making it open and available, because mining that kind of data set brings you to the great new discoveries that are ahead of us.
Okay.
Centers in the world who do collect in the framework of studies, or if it's Harvard, or we try to do that also, but I think there has to be some kind of enforcement for every physician to know the outcome, 3 months, 1 year later, and so forth. That was my final question.
Thank you very much indeed. That sadly, I'm afraid we can't take any more questions. We could go on. There's so much in this report that we haven't really sort of touched on, but a lot of other areas that we have. It's been a very, very stimulating discussion. It's raised a lot of interesting points and interesting questions. Do get your hands on this report. Hopefully there'll be some as you go outside. But also what I'd say is that there is a chance to meet all the authors of this report, I think in the Innovation Center later today at 3:45. So if you have any more further questions. So just leaves me to say thank you very much to our sort of panel. Give them a big round of applause. To David Bates, Annette Grossmuller, Effie Vanyena, Ahmed El-Garmed, Mauricio Vecchioni, and Aziz Sheikh. Thank you all very much indeed. And thank you.